Okay. So I've um, so I've just cut to a picture of the stage, and I'm talking. You might need to. You might need to unmute it on there. Yeah. I'll say it again. Hello. It's actually quite low. Yep. It will be a little bit behind. Yeah. Okay. Well, that's good.
Good afternoon, everyone. Welcome back to our afternoon session. We would like to start at 2 o'clock on the dot, if we can. We have our workshops going on for those of you who are here in person. And for our online guests, we have 2 talks that are going to be in the main room. So if you could make your way now to your workshop. If you selected Beth Russell's talk, that's in this main hall. Hayley and Jenny, they are in the Brockway room, and Illy is in our Bertrand Russell room. And we also have our wellness activity with Alexa in the library. So make your way to where you need to be. And if you want to get some cake en route, feel free to do so. Thank you. Those of you who are staying in the main hall, please could you be seated now? And I'm going to be welcoming our next speaker. And perhaps if we could have the doors closed as well, that would be great. Thank you, everyone. If everyone can now be seated in the main hall or find your way to your workshop. The workshops are starting now, so go and find wherever you have selected to be. If we could close the doors as well, that would be perfect. If you're leaving, could you close the doors and everyone come and sit down? Thank you. Thank you and welcome back to our 10th annual Birth Trauma Summit. And I'd particularly like to welcome our online audience as well. You are really important to us. Do use Slido and input your questions. If you are staying in this room, please could you find your seats now? So I'm delighted to welcome Beth Russell today. Beth is just a wonderful supporter of Make Birth Better, and I feel like our paths cross at sort of every opportunity, really. And today, Beth is going to be talking about acknowledging and overcoming the barriers healthcare professionals face in facilitating informed consent. So it's one of those subjects that's really close to our hearts, isn't it? So Beth is a midwife and a mother. She does have her little baby with her today, and they're very welcome as well. And her mother is here, so you're welcome too. And Beth has worked in the NHS and the charity sector for many, many years. She's currently still on maternity leave, but she's with us today, so that's just amazing. And she has worked for Birthrights, the UK Human Rights in Childbirth Charity since around 2022. And she has this particular interest in informed consent conversations and the real impact of psychological distress in maternity staff on women and birthing people's experience of their maternity care. So I'd really like to welcome Beth to the table.
Thank you so much, Trudy, and thank you to Make Birth Better for having me here today. I'm incredibly grateful to have been asked and to be able to speak alongside such an incredible panel of speakers. So yes, as Trudy says, I'm Beth. I am a midwife by background. I've worked in all areas of maternity, and I was a nurse before I became a midwife. The majority of my clinical practice has been as a community midwife and working doing NHS debriefs in kind of birth reflections type services. And as Trudy says, I've also worked for Birthright since 2022, initially on our advice service and now as part of the training team. And I'm currently on maternity leave, and my little girl is the one that you've heard whooping from time to time at opportune moments. So yes, I'm currently in that kind of sleep-deprived, joyous year postpartum. Could I have the first slide? Or do I use this, Trudy? I'm not sure if I should. There we go, sorry. So yeah, today I'm going to be talking about acknowledging and overcoming the barriers that we face as healthcare professionals in facilitating informed consent in our kind of current practice reality. So as Despina went through earlier, the law in the UK is really clear that women and birthing people have the right to make decisions about their bodies. They have the right to bodily autonomy. And we as healthcare professionals have a duty to make sure that we're giving evidence-based, unbiased information. We may make recommendations around what in a particular circumstance we feel might be the best thing, but we should always be giving reasonable alternatives and giving unbiased, evidence-based information on the risks and benefits of those reasonable alternatives as well. And then making sure that we are supporting women and birthing people in their informed choices, regardless of whether they follow guidelines and regardless of whether or not we agree with them ourselves. When we're talking about risk discussions, it's incredibly important that we are listening to women and birthing people, because the only way that we will be able to assess what is a material risk to that individual is if we listen to what they value, what's important to them, and what matters to them in this particular scenario. So dialogue is really, really key, and these are all things that came out of the Montgomery judgment in 2015. This has been the law now for 10 years, but unfortunately I think we're still far away from this being the practice reality for many women and birthing people in their journeys, as Despina mentioned. And as Despina said as well, just signing a consent form means absolutely nothing if there hasn't been a conversation gone before that where the woman or birthing person feels that they've been enabled to understand the material risks of the various options available to them. So the law is really clear, but what we know is that in practice, women and birthing people do not feel listened to, they do not feel heard, and all too often are experiencing births as traumatic. And many of our kind of reports have come out to say, we need to be listening to women and birthing people better. We need to be making sure that women and birthing people's voices are heard, and that's fantastic. But it's been years and years and years of reports saying very similar things, and still we're yet to see a real change and a real shift in how births are experienced by women and birthing people. And I really don't feel it's as simple as saying, to healthcare professionals, you need to do better, you need to listen to women and birthing people, because actually healthcare professionals themselves are facing a number of barriers that make this really difficult. It's absolutely unacceptable that we are in a situation where the rates of birth trauma are as high as they are, and many healthcare professionals are implicated in that, but I think a lot of the time those same healthcare professionals are facing extreme pressures, extreme challenges, and many of the systems that oppress the women and birthing people that we are supporting also oppress the staff that are working within that system. And so it's not as simple as saying, listen to women and birthing people, do better. We need to kind of unpack what's going on that's meaning we're not doing this, that we're not getting there. So there are many, many, many barriers to facilitating informed consent or legally sound informed consent in our maternity system. In a 20-minute presentation, there is no way that I could go into every single one of these and do them justice. So I'm going to pick out just a few. And in order to kind of illustrate that, I'm going to take you through a scenario. So I'm just going to look at my notes here. I want you to put yourselves in the shoes of an experienced midwife who's recently rotated to the delivery suite. You were supposed to have some supernumerary time to settle in, but due to short staffing, you were counted within the numbers, providing high-risk labour care from day one. A few weeks in, you're caring for a woman called Emily who's having an induction of labour for preeclampsia. Emily changed her position to get more comfortable, and it took you a couple of minutes to find the baby's heartbeat again with the CTG monitor. When you find it, it's 60 beats per minute and not recovering. There's a fetal bradycardia, and Emily is rushed for a Category 1 caesarean. Her baby needs resuscitation and is admitted to the neonatal intensive care unit for cooling therapy. When you get home from your night shift, you struggle to sleep. You keep getting flashbacks to Emily's frightened face, her words echoing in your mind, saying, "Please tell me my baby's going to be okay." And all you can answer is, "We're doing our very best for her." It was awful. There'd been a staff debrief at the end of the shift, but you had to leave before the debrief finished as you needed to get home to do the nursery run. And all you keep thinking is, what if I miss something? What if the baby doesn't make it? You squeeze your daughter a little tighter as you drop her off to nursery that morning. The following night shift, the coordinator kindly says to you, "Your night was awful last night. Why don't you go and catch a lovely baby in room 7? She's low risk, and it sounds like she's going to have a baby at any minute now." You take a rapid handover from the day midwife, who explains that the woman, Jenny, began declining intermittent auscultation the last couple of times it was offered, and that she's talked through the risks with her. Jenny's birth plan clearly states that she wants the midwife to be as hands-off as possible. You introduce yourself to Jenny and her partner Sam, you're trying your best not to disturb the calm atmosphere. As time goes on, you begin feeling increasingly anxious about the fact that Jenny doesn't want fetal monitoring. Your mind keeps flashing back to the events of last night, thinking, what if the same thing's happening again and I can't hear the baby struggling? I can't let another family go through that. You pull up the fetal monitoring guidance, but there's no mention of what to do if somebody declines all monitoring. It simply says, support the woman's decision about fetal monitoring in labour. Your mind is racing. A rising panic is building inside you as you think again of the baby being wheeled off to NICU yesterday. Between the contractions, you gently say, "Jenny, I just want to talk to you about listening to the baby's heartbeat. It's the only way for me to check baby's okay, and I need to do that every 5 minutes now that we're in the pushing part." Jenny says, "I'm finding it really distracting. I know she's okay, I can feel her moving." And you respond, "I hear you. I'll do it as subtly as I can. Sometimes babies move a lot when they're in distress too, so we really do need to make sure she's okay in there. I just really don't want for anything bad to happen to her." Another contraction comes, and when it's over, you move closer with the Doppler and say, "Is it okay for me to listen now?" And Jenny says, "If you must." However, when you listen after the next contraction, Jenny shouts, "Stop, that's really uncomfortable. I need to be able to move." You apologise, and you feel your hands begin to shake. You feel immobilised and overwhelmed. You can't think straight. You go to the coordinator for support. The coordinator comes in and begins to talk things through with Jenny and Sam, but Sam says, "Please stop, can't you see how upset you're making her?" Another contraction comes, and now the top of baby's head is visible at the height of the contraction. The atmosphere in the room is tense. Another contraction comes, and now baby's head is crowning, no longer retracting between pushes. You encourage Jenny that she's doing beautifully, and her baby is nearly here. Your heart is beating fast as your eyes flick to the resuscitaire, hoping that you won't need it today. With the next contraction, baby's head is born, quickly followed by her body. You lift her to Jenny's chest, rubbing her as you do so. The wait for the baby's first breath feels like a lifetime. But then the baby's crying. Her little cheeks are going pink as her parents cuddle her up and welcome her to the world. You breathe a sigh of relief. Jenny had the vaginal birth that she hoped for. However, whenever she tries to speak about her birth in the weeks that follow, she becomes tearful and upset. She blames herself for not advocating for herself more strongly. Of course, she's glad that her baby's here safely, but she still can't help feeling sad that her birth was so far from the peaceful experience she had hoped and planned for. She felt completely out of control and like nobody was listening to her. So this scenario is based on some of my own personal experiences as a midwife, as well as some of the stories that I've been privileged to hear in my many roles over the last few years. And I think many of us who are healthcare professionals in the room can probably relate to shifts that have felt like this, to moments where we felt like this. So let's look at the barriers that faced this midwife. So initially there was that lack of support. Yes, she was an experienced midwife, but going back onto the delivery suite after who knows how much time elsewhere, many things may have felt unfamiliar, and I think we can all probably relate to times where, because of having to be on top of certain paperwork or not being sure of certain policies and wanting to make sure we get it right for the woman or birthing person, we are distracted from being in the room with that woman or birthing person and distracted from truly being with them in their experience. Something that's often really not recognised in our work as midwives, obstetricians, maternity support workers, anybody really working in the healthcare space, is that there is an inherent risk of trauma for every single one of us, every single time we go to work. It's not if we're going to experience trauma at some point, it's when, because of the nature of the work that we do. And yet there isn't really scaffolding to support us to make sure that we are psychologically safe and that we are the safest pair of hands to be caring for the person in front of us. When we think of the work that psychologists do, for example, it's an expectation, a kind of professional expectation, that there will be clinical supervision to make sure that person has worked through their own thing so that they can be the safest pair of hands for the people that they are supporting. And we don't get that as midwives, as obstetricians, as maternity support workers. There are some systems in place, such as the Professional Midwifery Advocate Service, but it often fails to give people the opportunity to really unpack their own trauma or to be properly supported if they have witnessed something traumatic at work. And that is bound to influence how we then go on to provide care in future. So many healthcare professionals will be walking around experiencing symptoms of vicarious trauma. And that may not be from one specific event. It can be from a build-up of a number of things that they've witnessed over the years and leave them feeling in this really quite unsafe headspace whilst they're doing their work. There's a real lack of individualised psychological support. So we saw in this example, she wasn't able to stay for the debrief because she had to get off the nursery run. We should all be able to expect that if something really challenging has happened in our work, that we are afforded the time and space to unpack that psychologically within our working hours. But very often that's not the case. Often debriefs for professionals will happen either after the shift or maybe on a different day where you may yourself be on a day off. Much of the psychological support that may be offered if somebody is going through difficulties relating to something that they have seen will happen on their days off. And so for somebody with a young family, how accessible is that really? I think I've come to really appreciate that now, becoming a mother myself. All of my hours when I return to work, all of my hours outside of working will be spent mothering. So where is my time to make sure that I'm okay, to make sure that I'm safe, to make sure that I'm up to date so that I can provide the safest possible care? In this scenario, we can see a number of competing demands in that she had this kind of demand upon her that she just really wanted to know that the baby was okay. And really that was kind of for her because of what she'd witnessed the day before. She also had the demand that I really want to make sure that this birth space is calm and that it's the calm space that this couple have wanted and planned for. And she had the competing demand of trying to do right by the coordinator and her colleagues and everything else that was kind of going on there. There was a lack of clarity from the guidelines in this example, and this is kind of a much bigger subject really, but our guidelines are subject to all the same biases that healthcare practice is subjected to. So the research that actually makes it into guidelines sometimes is kind of, it can be cherry-picked, not necessarily intentionally, but just influenced by what those professionals themselves deem to be important. I remember being told that it wasn't possible for us to include the big meta-analysis on home birth when I was trying to do some updates to one of the guidelines in a local trust. But when it came to rationale for induction of labour for a very specific situation, it was okay for us to be using a very small study that took place in America. And there was kind of a real bias there around what those that were leading that guidance felt needed to be included in that guidance. So our guidelines are are many times fantastic, but they are also not perfect. When we're talking about kind of risks with people, the ideal is that we use absolute risk. So we say, oh, the chance of X happening increases from 1 in 100 to 1, it goes from 1 in 200 to 1 in 100. However, much of our guidelines doesn't have that numerical data available to us. And for healthcare professionals who are already incredibly rushed and busy, it can be really difficult to try and extrapolate that from the raw research kind of on the fly as we're doing our jobs. Many healthcare professionals don't have the kind of research literacy that we would like to have. I myself did a master's to try and see if I could improve that, and still some quantitative research absolutely baffles me. And so if we can't look to our guidelines when we're in these moments, what are we to do? You know, we haven't got those resources there that we truly need. There was also this inflexible approach to the guidelines, which said, I need to listen to the baby's heartbeat every 5 minutes because that's what the guideline says. Where actually, if we view guidelines as the guide that they are, we can understand that, you know, yes, that might be the recommendation, but we need to talk about the reasons around that in an evidence-based, supportive way so that that person can make their own decision. There was clearly a lack of awareness of informed consent law, or if this midwife did have that awareness, that was completely blindsided by the stress that she was placed under, by the kind of psychological state that she was in herself. Because, you know, nobody that truly understands the law is going to stand there and say to somebody, we need to listen to your baby every 5 minutes, or, you know, how am I to know that your baby is not in real trouble here? That's incredibly coercive. We also saw this overwhelming sense of responsibility. She was saying, I can't let this family go through what the family went through yesterday. And that might be a trauma response because of what she's witnessed. That might be her kind of going into that saviour mode and sort of feeling, you know, I really can't let somebody else go through that. But it also, I think, speaks to the overwhelming responsibility that we all have as healthcare professionals, even though when we're guiding somebody through their decision-making, the choice is their responsibility, but the responsibility of having the conversation effectively is ours, and that feels like a lot sometimes. It can, the amount of times I've come away from situations and thought, did I do that in the right way? Did I make sure that I was clear enough about the risks of this and made it also clear that I really wanted to support them in their choice? And that's incredibly difficult. And so the impact of some of these barriers, we saw this decreased window of tolerance. She was clearly in this really sort of hyper-aroused state. She was, her nervous system was, you know, in that real fight or flight mode. And so she wasn't really able to see the wood for the trees. She was not able to see the bigger picture, really not able to see that in this situation, the day before, there had been some real risk factors for that baby struggling more in labour. But in today's scenario where there's somebody very low risk, that risk of something happening to the baby felt massive to her because something awful had happened to the baby that she was looking after yesterday. She'd lost sight of the fact that actually the chance of there being any kind of fetal compromise is relatively small. It's still important to talk about, still important that the woman Jenny was able to make her own informed decision about intermittent auscultation. But for her, that risk felt huge because of what she'd witnessed the day before, when statistically, for Jenny, the risk of something happening to her baby was would have been smaller than Emily that she was looking after the day before. So there was that real fixation on one perceived risk. So that psychological distress that she's experiencing, that was impacting her ability to provide care, but also could have ongoing impacts for her as a human being, as a midwife in her future practice. What we saw was this kind of coercion with kindness. So she was saying it very nicely, you know, I need to listen to the baby every 5 minutes now, and saying it in a kind of very gentle, kind way and coming across as, you know, trying to be really nice. But she wasn't giving any choice to Jenny. She wasn't giving her any option or any out. And in many ways, that can be even more harmful for women and birthing people because there's this sense of, oh, but they're so lovely. I don't want to speak up against them. I don't want to upset them. I don't want to make them feel that I don't like them or that I'm unhappy with them in any way. And so that coercion with kindness in the work that I do doing NHS debriefs is something that I hear all too often. It's like I just felt that I was never given a choice. The midwife was lovely, but I just never felt like I had any other option than to do what she was saying I should do. And we know how incredibly harmful that lack of choice and control can be. Ultimately, the system was prioritised over Jenny's needs. Her need to make sure that she followed the guideline, that she heard that baby's heartbeat and made sure that baby was okay, completely overshadowed Jenny's need to be listened to be supported. And actually, she lost sight of the fact that this baby was coming, this baby was about to be born, and ideally what she would have been able to do in that moment would be have a gentle conversation around, I understand that you've declined intermittent monitoring, I just want to check that you understand the risks around that, are you happy to continue, a kind of gentle conversation, and then just been with her as her baby was being welcomed into the world. So there was that real loss of trust between the midwife and the couple. And I'm sure we've all seen situations where that loss of trust becomes lifelong, becomes something that sits with that person forever and impacts on how safe they feel accessing care in the future. A seemingly small thing can have a profound impact for a really long time. And ultimately, the birth was experienced as traumatic for Jenny and Sam, and that can never be taken away. This midwife had no malintent. She clearly wanted to do right by the women and birthing people in her care and was thinking along the right lines, like trying to prioritise safety, prioritise that calm atmosphere. But ultimately, even this midwife, who is a compassionate, thoughtful person, ended up causing trauma inadvertently. And I think that's what we see all too often in our system. Maternity staff's working conditions are women and birthing people's birthing conditions. I've worked in the NHS now for 14 years, and in that time, there's not a year that's gone by that either I or people around me haven't been having conversations around, I feel like I'm unable to give the level of care that I came into this job to provide. And so if we as healthcare staff are speaking up saying, we need more resources, we need more staff, we need better, and we're not listened to, we're not listened to, we're not listened to. Is it any wonder that that same not being listened to translates to the people in our care, that we kind of become the victim of the system ourselves and then are unable to prioritise the person that we're there to support in our role? It's not all bad news though, because I'm aware this feels very heavy. In just the last 4 years, I've seen a massive change in practice in my local area. So I remember when I was working on a home birth team, caring for somebody who'd had a previous postpartum hemorrhage, absolutely did not want to birth on the delivery suite. That was a hard no for her, but was really keen to be on the midwifery-led birthing unit. That's where she felt safest. However, at the time, the guidance was clear that anybody with such risk factors wouldn't be supported on the midwifery-led unit, and I spoke to senior leadership and was told, look, our hands are tied, this is what the guidelines are, she either comes through to delivery suite or we can't stop her giving birth at home, so you'll have to support her with that if that's what she wants. And it was this kind of, and at the time I didn't work for Birthrights, I didn't have the knowledge of the legal framework that I now have, and so I was only able to apologise to her and say, I'm so sorry, but I will do everything I can to help you feel as safe as possible and all of that. She had a wonderful healing home birth and nothing untoward happened, but that obviously could have been very different, and she was not supported in her choice of place of birth as a result of those kind of systemic issues. Whereas now, anybody in a similar situation, and many people with many more complexities, have been supported to be on the midwifery-led unit. They've had a personalised plan put in place, and there's real excellent support around that. And that's just in the last 4 years. And to me, that feels like a massive shift and change in practice. So we are taking steps in the right direction. It's taking too long, but we are getting there, and we will get there. I just wanted to kind of take a moment to pause and think about how we as clinicians can overcome some of these barriers, these huge issues facing the NHS, like understaffing, under-resourcing. As one person, it's really difficult to try and change those alone, but there are small things that we can do for ourselves. So when we start to really critically look at our own practice, it can be incredibly confronting if we're looking at experiences where we think, yeah, I was probably complicit in that person experiencing birth trauma. That is really, really, really hard. And so I would encourage everybody that is kind of working in this space to have self-compassion, cultivate ways to be compassionate with yourself as you start to reflect on past practices. Something that's always really helped me when I have been kind of struggling with this is the Maya Angelou quote that you do the best you can with the knowledge that you have, and when you know better, you do better. And that's what each and every one of us can do in our practice. We can take that with us today. Second is knowledge. So I have really seen a shift in my ability to practice in a truly person-centred way since working for Birthrights and having that real deep understanding of the legal framework, because although it still feels heavy and hard having conversations that feel quite big. I know that even if there's disapproval from colleagues or it's really far outside the guidelines, that I'm doing right by the person in front of me and I'm doing right in the eyes of the law. And so that kind of legal knowledge is incredibly important and can be incredibly helpful. I think we will all report when things like postpartum hemorrhage happens, when a shoulder dystocia happens, when serious clinical incidents happen. We know that the outcome of birth trauma for many women and birthing people can be just as serious. And so we should be reporting when we are put in situations where we can't have adequate informed consent conversations. So those times where we're trying to get hold of an interpreter and there's not an appropriate interpreter available, or we have concerns around how that information is being relayed. Those times where the appointment times that we have are just simply too short to have the nuanced, evidence-based, thoughtful conversation that we need to have with that person in front of us. We should be reporting that because that is what is going to help us push forward change. Our managers, and sorry to those of you that are working in senior leadership in the room, will probably be fed up of the number of incident reports that come through, but that is the way that we create change and evidence. We need better. We need far better if we're to be able to truly support women and birthing people in their choices. I think self-reflection is also really important because every single one of us has biases. There may be some that we are aware of, and there may be other things that we are kind of completely unaware of. And we all have a duty, because our legal duty is to give evidence-based, unbiased information in order to support people in their choices. We all have a duty to really look at, okay, what are my biases? And if we're finding something really uncomfortable, to take that away and interrogate it to understand what's coming up for us, so that we truly can come as close to kind of practicing from neutrality as we possibly can. So whether that's through journaling, speaking with trusted colleagues, talking it out with other professionals, whatever it might be, that self-reflection is really important. I also think if we put ourselves in the shoes of the women and birthing people that we're supporting, that can really help us to take a step back and see the bigger picture, see the potential long-term impact, because I now know myself from my own birth experiences and experience of being pregnant, just how weighty that responsibility feels when you are making a decision for this little life that you already care so much for, more than you ever knew possible. That weight of responsibility of making decisions that could affect them already feels massive. So if we can put ourselves in the shoes of the woman or birthing person that is trying to do that, we can understand how, we can understand how for healthcare professionals, for us as healthcare professionals, it's incredibly important that the information we're giving is not coercing people in one direction or another, and is really helping them to sit with the decision and make the decision themselves. I think being aware of our nervous system, we could see in this scenario just how stressed this midwife was feeling. If we can be aware of how that feels for us as individuals in our bodies and cultivate ways that work for us to just bring ourselves back down a little bit, whether that's some breath work, some somatic practices, just taking a pause before we speak, whatever it might be, being kind of aware of our nervous system so that when we're responding, we are doing so from a place where we're seeing, we're sort of hopefully widening our window of tolerance to everything that's going on around us. And sharing the load. So even the most senior obstetric consultants, consultant midwives will need support with this sometimes, because it can feel massive, and we do come across circumstances that are incredibly unusual where we will need the support of colleagues, and sometimes where we will need the support of outside organisations like Make Birth Better, like Birthrights, to help us kind of make sure that we're managing things in the safest way and a way that really centres the woman or birthing person in front of us. Thank you. I'm aware that I might have gone over slightly. So thank you ever so much. Are there any questions? Thank you, Jo. Yes.
So if you've gone into the university route, or you were a nurse first and you're going that route, is there any pathway where you get to unpack your own trauma that you might be bringing with you, or any biases as you're training to be a midwife, or is it just academic qualification, go
My experience was academic qualification, off you go. It may be that things are
Beth,
changing.
can you just repeat the question into the mic so in the live stream people can see
Sorry,
it?
yeah, of course.
That's
so,
our fault.
Joe wanted to know whether the lack of support for midwives, obstetricians, healthcare professionals around their sort of psychological support, whether that starts in training. So whether during your training you're given an opportunity to unpack or debrief your own birth experience or own kind of traumas before you start practicing. And so my answer was, my experience was that never happened for me. It may be that things have changed in the years since, and I would really love to see that changed. I know that many of our doula colleagues, that is a part of kind of training to become a doula, is unpacking and debriefing your own birth experiences. And I do really think that would be incredibly important for all of us working in maternity care, because many people come into this work because of their own experiences, whether they've been traumatic, whether they've been incredibly positive, but all of that brings bias. So yeah, I would like to see that happen. As far as I'm aware, that doesn't happen at the moment. Thank you, Jo.
What do you think about consent forms?
Okay, so the question was, what do you think about consent forms?
Yeah.
What do you think about consent forms? Yes.
So I do think they are important in terms of they are a legal document, but they are meaningless if somebody is being rushed to theatre and just being asked to sign and there's no conversation that's gone before that, because it really is meaningless. Because if I'm signing something but I don't really know what I'm signing, how is that following what Montgomery asks us to follow? It simply doesn't. So yes, they are important, but it's the conversation that goes before and the documentation of that conversation that goes before that, in my view, is far more important. I do think what we need to see is improvements in how that happens in emergencies, because of course when there's a fetal bradycardia or there's something really acute going on, we need to act quickly, but at the same time that woman or birthing person needs the opportunity to really understand the risks and benefits of what they're consenting to, and I think we definitely need to see improvements around how that's happening.
Oh, last question here. Last question, then we've got to wrap up.
Kind of follows on from Ellie's question. What are your... So I'm an obstetrician and I facilitate our out-of-guidance care in our trust. Yeah. And we go backwards and forwards a little bit around documentation, because it's really easy to just write, risks and benefits discussed. That's what that can mean, anything. And unfortunately, I think probably most of us have been involved in cases where a woman or birthing person has then said retrospectively, following a poor outcome, oh, I didn't really understand. Yeah. I said I wanted that, but I didn't really understand. And one of the things that I do some of my work on Teams, and I often ask for consent to record for both of our benefits, and that seems to be working well. Yeah. But I don't know what your thoughts are about kind of recording conversations, because it's gone down very well with the people that I've looked after so far, but I think a lot of birth workers find it quite confronting and challenging to think about being recorded, in that it might break down your trust and your relationship. Yeah, so I think what's always worked for me is trying to record the conversation as close to how I had it as possible. So sometimes writing things like, in discussing this, I was considering X, Y, or Z, so it's kind of more personalised. But also, there are situations where having kind of... I was doing some work on our out-of-guidance guideline, and within that we created kind of proformas of things that, these are the things that you absolutely need to make sure you've discussed, and we were kind of signed to say we've discussed each of these, but then also recording a bit of more of a personalised discussion underneath. And I think that way we can be sure, yes, we've discussed all of these things that are, really important. We've also discussed these things because this person has told me this is what they feel to be really important to them. Does that answer the question? I'm not sure if I have... Yes, I think that would be a really positive way of doing things, because I think it would make people think twice about what they're saying, because I think, we are all rushed, we're all busy, and sometimes we say things in a way that isn't so considered, and we can easily forget about it because, for us, that's, one clinic appointment done, off we go. But if we are aware that that's being recorded, and that is a legal document, that recording is a legal document, we will, all of us, be much more cautious about the words that we use. We'll take that pause because we'll be thinking, I really want to get this right.
hopefully for the woman or birthing person in front of us, but also because I need to, legally, I need to. There's evidence of whether I've done that or not. So I think that would be a really positive way of doing things and would also save us a heap of time, because documenting those conversations, I can sometimes spend like an hour on an appointment where we're going through lots of different things and then another half an hour or more documenting. And that's, you know, a big use of, you know, time when someone's being paid, you know, band 7, band 8 or, you know, consultant obstetrician wage. That's a big use of time. So yeah, I think that would be fantastic, to be honest. Thank you.
Thank you, Beth, so much. There is an awful lot for us to take on board with that. But the law is clear. Women and birthing people have the right to make these choices about their bodies. But we also need to support the choices of our healthcare professionals and really help them navigate all those barriers that exist in that birthing space. So thank you so much, and I'd just like everyone to take their seats if you are coming in for the next main speaker in the main hall. If you have a workshop that you are going to, please find your way to that workshop now, as we are going to be moving on with our speakers on the main stage. So I would like to now welcome Claire Feely. Claire is going to be talking about compassionate support for healthcare professionals, and it really fits and sits well alongside our previous speaker. So qualifying as a midwife in 2011, earning an MSc in 2015, a PhD in 2019. Golly, Claire, you've worked incredibly hard. Claire has worked clinically in all areas of midwifery and in many, many different settings across various organisations. She specialised in physiological birth across the risk spectrum. And Claire's primary research focus has been on the socio-cultural, political interactions upon women and birthing people's access to engagement with and their experiences of maternity care. So I'd like to welcome Claire to the stage.
I'm not sure if this is working. That is. Is this working if I stand back? Oh, it is now. A bit loud. Thanks so much, Trudy, for that introduction. And I was just reflecting, as it's 10 years for Make Birth Better, what was I doing 10 years ago? And I was a part-time community midwife. Big shout out to Caroline over there. We haven't connected since I left that trust, and I've seen her today. It's made my heart absolutely sing. And I was also part-time on my master's and doing my first research study, where I interviewed these wonderful women to explore their motivations for free birth. And it was the first study done in the UK at the time. And so now I'm just looking back 10 years, oh my God, a lot's changed, a lot's happened. And I'm no longer a community midwife. I'm in academia full-time now. I wish I had the time to fit it all in. So yes, I'm currently an academic, educator, researcher at King's College London, and I was really pleased when I was invited to talk about compassionate support for healthcare professionals. It has come from my PhD work as well, issues around how important our work environment is in order to deliver the care that women and birthing people and their families deserve. So this might be a little bit of a rant to start with, but let's see where we go and how we go. And that's the screen that I wanted. I really love this image. I'm obsessed with trees. Oak trees is my new pet passion at the moment. So and I just love this image. This is what we all need to be doing for each other. So let's take stock. And I'm talking specifically to healthcare professionals, specifically to those of you who are working with an NHS or a similar environment, should we have any international guests here. Times are tough. The world feels and is on fire. Yet you are still getting up and going to work. You're doing your best to manage these clunky systems, the poor add expletives IT systems, the wayward equipment. Why is there never a sonic aid in your room? Why is there never a bright size blood pressure cuff when you need it? And you're trying to juggle many competing demands. Poor staffing, yeah, old news. Increased busyness, thanks to the IT systems, in part, and that's definitely a conversation for another day. That is not helping anyone. And the relentless need for documentation, and I'm thinking particularly of those of you who are in that clinical, immediate situation where, I mean, me and Cam were talking earlier, you've got this horrific, horrible, massive computer taking up all this energy and space in the room, and you've got your back to the birthing person, and trying to navigate 3 different systems just to document that pulse. So that is deeply problematic. And on this particular shift that you have got up for work, maybe you got a break, maybe you didn't. Maybe you got a chance for a wee, maybe you didn't. We know UTIs are a chronic problem in the nursing, doctors and midwifery workforce. And all of this, the functional stuff, that's a nightmare. You're trying to hold the line between these oppressive systems, and crap IT is an oppressive system, never mind before we get into the social, cultural, political context of maternity, right? That everyday frustration is oppressive. So while you're trying to hold your line between all these different oppressive systems, you're trying to maintain your ethical and moral values and delivering kind, compassionate, skillful care to those who are in your care. And you're trying to be present and attentive. And yet all of this is going on. Or someone walking down the corridor. Where are the keys? Where are the keys? Who's got the keys? Oh, God, did so-and-so go home with them? I'm getting the last because you've all been there. Why do we not have punch numbers on our CD drugs, right? For those who don't work clinically, I'm very sorry, some of this might go over. It's a massive bugbear of all of us who've worked on a ward. Why do we have old-fashioned keys? So it's a fight. It's a fight. And for many of you, every blinking day, all of this is going on. Because that IT system might have just got worse. Definitely had that conversation today. Maybe your trust didn't consult anyone and they've brought in something new, which is even worse than the old one. So you're fighting every day. That's exhausting. And from the nods and laughs I've got, I appreciate this probably does sound familiar. And I'm also mindful that for some of you, and that could be some of you online, this doesn't resonate. Oh my goodness, please send us your job adverts because some of us want to come and work with you. Because not everywhere is dire. It feels it in our collective psyche at the moment, but it isn't dire absolutely everywhere. But everyone's within the same global context of life feeling very difficult. But in terms of that clinical day, that clinical working, for too many, what I've just described is that lived reality of NHS working. It is different in our independent private models. So fundamentally, just to get us all on a downer, right? I want to bring to this conversation of how important you are, and your dignity and personhood is absolutely essential when we're talking about what is going on in maternity services. Without you, the health professionals, there is no service. AI is not going to take all of our jobs. It is not. It cannot. Okay? It can do some really fantastic things. It can also do some really stupid things. AI hallucinates. We are not there where it's going to be your midwife or your obstetric doctor weighing up, could this be a forceps or does it need to be a caesarean section? Without you, the health professionals, there's obviously no care provider. And for some women, some birthing people, they don't want us there. And my roots come from the free birthing community, who are so kind and welcoming when I wanted to draw upon their wisdom for my research. So that's fine. That's their right to do so. But for a majority, they do want our care. And without you, there's no one to comfort, reassure, or pick up on important issues. And again, AI can't do this. The fact that we've moved to so many machines that go ping in maternity is, quite frankly, a safety issue. We think that the automated blood pressure cuff, and unless it's in, you need to do it every 5 minutes, what are we missing when we're not touching people anymore? What are we missing if we've only got a pulse ox on and we haven't actually palpated that pulse by ourselves? Have we actually guaranteed that we've picked up the fetal heart by using a pinard whilst palpating the maternal pulse? We're losing these basic touching skills, which are safety issues, which we can pick up, and without you, we wouldn't be picking these things up. What I've just said is really, really important from a health service perspective. But more than that, you, all of us here, are a person, a human being worth dignity and respect, worthy of respect and dignity. Fundamentally, you do matter. And for some of us, taking time away from the work that we do is the only way that we can preserve ourselves. Others, we find a different path and we wind ourselves and go sideways before we go forward again. All of those decisions are equally valid, but you matter. And crucially, and one of my interests, which has come out of several of my different research projects, working environment matters. It's absolutely essential, and Beth said it so beautifully. The conditions in which women and birthing people birth in are the staff conditions, and vice versa. So what do health professionals need? So the King's Fund, I'm sure you've all heard of the King's Fund. If you haven't, you need to find them. Absolutely amazing organisation. They have done extensive work, and this one specific report is actually called The Courage of Compassion, so perfect for this talk today. The King's Fund wanted to look at the issues of retention for nurses and midwives, and they've done a parallel project with the GMC for doctors across all specialities. So this is reinforced. This is what doctors, nurses, and midwives need. But what they did, and I love this, from a research perspective, from my values perspective, looking at it from a salutogenic, a well-being perspective, what do we need in order to be engaged with our work? You all know the staff who have disengaged. They're there in body, but not in mind or emotion. So the King's Fund was asking, well, what do staff need to be engaged, to be well in the workplace, where the sense of well-being comes from, and even flourish, which I know we feel quite far removed from that. So they did all this massive amount of work. This report you can just find online. I've put it in the resources. It's open access. And what they came up with was this model, ABC model, and I use it a lot in my work and my research. And we've got this autonomy, belonging, and contribution. Now, before I dig into that from a work context, you might not be surprised to see that this is just basic human needs. This is what we all need. So we do all of this work about what doctors need, nurses need, midwives need, whoever else needs. But these are fundamental tenets of what we need, as psychological tenets of what we need to have well-being and to be engaged with our communities, with our lives, with our families, and to flourish. But I like the fact they've applied it into this work context, and specifically, it's UK-based NHS context. So autonomy, we all know what autonomy is. We definitely know when we don't have it. And that's that's an erosion that's happening, particularly with midwives. But it's the need to have control over one's work life, to be able to act consistently in one's values. Keep those two things together. It's not just doing what I want when I want. in this selfish context, although some might do that, but it's about working within our values. Think about how many times a day you don't feel you can work within your values. That's an erosion of your workplace autonomy. And all of this links into these bullet points that the authors, and Matthew West has been one of the key authors in this, and you'll all know him in relation to compassionate work. So authority, empowerment, and influence. So the other thing about autonomy is having a sense, can I influence my workplace? And not necessarily changing the whole mechanics and wheels of the NHS, but does my managers, or leadership team listen when something's gone wrong? Just that really simple thing. Oh, da-di-da's broken. Okay, there's a system and process that works to get that replaced reasonably quickly. Justice and fairness. Am I being discriminated against, or am I witnessing discrimination? We know black and brown midwives and nurses are more likely to be referred to the NMC under, vexatious complaints. Vexatious, racist discrimination complaints. When we work in a place where there is discrimination, even if we're not directly affected, it says so much about the culture and it reduces the overall psychological safety. Work conditions and work schedules. Do I have any sense of autonomy? And again, was very much in a nostalgic space earlier. I worked in an amazing team once upon a time, before the world went crazy, and we self-rostered. And we managed it, and there was never a day that wasn't covered, and we worked so much harder in that team. We looked after each other, we covered for each other to meet our own personal family needs. So autonomy is actually quite massive. It's bigger than that initial understanding. Belonging. The need to be connected to, cared for by, and also caring of our colleagues, and to feel valued, respected, and supported. Isn't it nice when someone knows you've had a rubbish shift the day before and they remember, and they go, oh, how are you, Stan? No, that was really rubbish. Or when someone just brings you a cup of tea because they know you haven't had a chance to sit down yet. So all of that comes to the team working. I think team working is kind of, I don't know, maybe we said the word too much or something. It feels like it's lost meaning. But it is so integral. Think how, you walk in and you see the board and you're like, say if you're on a labour ward or postnatal, you just see it and it just looks so dire and grim. Then you see who walks in for your shift and you're like, oh, we're going to be all right today. We're going to be fine. Equally, the opposite happens. And the power of one person who perhaps is, a bit of a negative Nancy or doesn't pull their weight, the negative influence that one person or two people, or God forbid, once you get into cliques, then that has such a damaging effect. And all of this contributes to the culture. The culture isn't something that happens to us. We contribute to that culture. And of course, leadership. Is that being role modelled? Contribution, I think, is such an important aspect for anyone who works with the public, and particularly in the health and social care services. We're doing it because we want to make a difference. Why would we have put ourselves through the degrees, or for medics, putting yourself through years and years and years and years of financial hardship if we didn't want to actually be effective in our roles? And that is something that's incredibly important to us as human beings. And you see that with parenting. There's so much knowledge now. Get your little ones to help and contribute, even if they make a really bad job of it. It doesn't matter. It's the sense of self-esteem that comes from that. So contribution relates to this need to experience effectiveness in work and deliver valued outcomes. When we can walk away and go, okay, I've not only done my best today, but I can see that it's had a positive impact. It's like those moments I have with my students, they might be falling asleep for half the day, and then suddenly something I've said, they just go, oh yeah, no, I get that. That's rewarding, and that feels like I've been effective. So we do know, and you know what you need anyway, and obviously there'll be variations between us as individuals. But linking this to this talk, focusing on compassionate support for health professionals, I just want to home in on belonging and from the ABC model. And just a reminder, that's the need to be connected to, cared for by, and caring for colleagues, and to feel valued, respected, and supported. Fundamentally, what that's saying is compassionate support. We want to feel supported by our team, where, our immediate team, the wider team, that the organisation cares that we're not just a bum on a seat and could be anyone. That literally is, I think we could argue, the definition of compassionate support. So you all know what compassion is, but let's just revisit it slightly, just quickly. So it's a sensitivity to suffering of self and others with a commitment to try and alleviate or prevent it. It does require courage, and it does require engagement with suffering. And it's much more than an emotion. Compassion is a doing, it's a verb. It's about engaging and taking action. When we feel too much sympathy is the words have failed me now. Sympathy is not a very empowering space to be. Whereas compassion is you're walking alongside and you're not going into saviour mode, but you want to work together to try and make that suffering stop. So when you think about and Beth's amazing example, I love running through that scenario. We talk about compassionate care all the time, and the evidence is irrefutable now that we cannot, the improvement to outcomes, the evidence is growing over and over. It's just enormous. Professor Jeremy Howick, I suggest you find him, because he's found it just even in terms of preventing mortality rates for those who've experienced heart attack. Compassionate care makes all the difference. So we know how important it is in terms of our roles to those in our care. But within the workplace, we can connect this to belonging and being cared for by our teammates. But it does require an attunement to each other. It does require a level of self-awareness and awareness of what's going on around us to help us recognize when our colleagues are suffering or struggling, and or being able to reach out and ask for help. Because it's really scary, isn't it? It's quite a vulnerable place to be. But this is crucially about taking action to help. So this might be about self-help, and it might be about acknowledging, what if your coordinator's just had 3 emergencies? Maybe she needs a cup of tea. Maybe she needs a little bit of decompression. If you're a senior midwife, maybe you could take over. So from an organisational perspective, compassionate organisational support, because this is the environment in which we're working in. Resilience is now the dirty word because it was a used and abused term to help prop up the failing systems. So we don't want compassion to become like that. So I like to focus on it from an organisational perspective. And this needs to be an underpinning assumption that all staff deserve compassionate support. Wherever you are in the service, however part-time, however full-time, whatever grade or band you are, the underpinning assumption of that organisation is that everyone is worthy of respect, dignity and compassion. It needs to be embedded within the system procedures and processes because they all contribute to the culture. If you don't feel safe enough to own up to a mistake that you've made, that whole system is failing, and we can see that within all the major reports. If you know you're going to be treated with respect and kindness and dignity, you are going to own up to that drug error, etc. But it has to be role modelled by the seniors throughout the organisation. If you're privy to senior leaders bitching about someone behind their back, that is obviously not going to be compassionate support, and you're not going to feel comfortable talking, or you'll be worried about what they're saying about you. So when it's role modelled, when this is genuinely role modelled, positive behaviours are reinforced and perpetuated, and then it grows, doesn't it? Then we start doing it to each other. But this also has to be seen within a personal responsibility. We cannot see culture as something that's just happening to us. We are contributing to that. So are we going to sit in there and gossip about our colleagues, or are we going to walk away? Even if we don't feel confident challenging, are we just going to walk out the room because that's not okay? The other thing I would add to this, and I know I've only got a couple of minutes left, compassionate from an organisation, your leaders, your colleagues, your team leads, is so important, as is self-compassion. But I would also couple this with grace. None of us are our best selves every single hour of every single day on shift. We have to extend grace to ourselves if we have made a real mess up or we have been a bit short and snappy with a colleague. Own it, take responsibility, apologise, move on, but just you can be kind to yourself. And I always think about this example, you know, as a newly qualified, going to the coordinator, asking a very banal question, which is fine, newly qualified should ask banal questions, but, you know, where are the Inco pads? She bit my head off, okay, go away a little bit hurt, oh, I don't know about her, and I don't think she likes me, and all of this negative stuff. But with a bit of time and processing, oh, hang on, I didn't clock, there are 3 emergencies going off. I didn't realise the stress that she was under. Oh, I can extend her grace and not make it so much about me. So we have to couple this with grace. For any of you who do night shifts, most of you, some of you might be full night owls, but 5 o'clock in the morning, you're not going to get the best from me, that's for sure. So these things have to come together. And I know our students feel incredibly vulnerable if someone's been a bit sharp with them, a bit short. And there is a big difference between that and bullying and being horrible to each other. And this is where the grace comes into, and decentering ourselves in some of the narratives that we all have as human beings. So the implications of staff, I've really talked about this, whether or not compassionate support is in the workplace makes a key difference. It's either a key driver or driver for stress, ill health, mental health difficulties, suicidal ideation, suicide actual, successful suicide, burnout, all of those things, or it's a preventative measure. So this cannot be ignored at how important it is. And for those, Beth was absolutely right, all of us are going to experience something incredibly distressing or traumatic within the workplace, even in the best team, even the most compassionate team, but compassionate leadership, compassionate support is the mitigating factor to help you process and mitigate the damaging impact. And of course, it makes a discernible impact. I know I've got 30 seconds, but I have to link it to what has this got to do with birth trauma. One slide, I promise. Staff interactions, we know. When we think about the back to basics on birth trauma, which is what today was about, it means that we have to consider the workforce, their needs and well-being. Not centre them entirely, but we have to consider them. A poorly workforce cannot deliver safe, compassionate, respectful care, which is the key protector against trauma. Growing evidence as well over the past 10 years has demonstrated that maternity events are not necessarily what causes the birth trauma. It's more and more being demonstrated, it's the care received, the care interactions when something has, going for that emergency section might be really, really disappointing, distressing, but the difference between it becoming a horrible, traumatic experience resulting in PTSD, never wanting to have any children again, the difference is in the carer and the care received. And that's that's a wider presentation, but this is the point. This is why linking staff well-being with women's birth trauma, birthing people's trauma, is so important. So very often it's the interactions which are the source of trauma. So it's not necessarily what happened, but how it happened. So any birth or perinatal trauma, because certainly that we're widening that conversation now, absolutely does need a conversation with and about the workforce. And for me, the most important thing here is the workplace environments. What are those staff coming into every day? Solutions to overcoming and reducing the rates of perinatal trauma has to consider these multi-factors involved. And on this one, but I know I've got to finish, there were some positive innovations because it all feels so negative and everything's terrible, but there's some great stuff going on. And we've got an open access paper where we did some work around attrition and retention in a unit, and they had retention midwives in post, and we evaluated what they did. And I'll just share what they did. They did massive amount of work. These are brilliant, brilliant women. Listening events, team away days, restorative supervision, well-being within the hospital setting, so bringing reflexologists and masseuses into the hospital, so it's done in work time. External psychotherapy, I know we talked about that earlier, and Joe would love to follow up that conversation about all of those types of things. And introducing something called Greatix. You will all be very familiar with Datix, of when things go wrong. Greatix is when you see your colleagues done something great, and then you submit that, and everyone gets to hear about it. lots of other innovations going on, and I would love to hear from other people in terms of what innovations happen in your workplace to improve compassionate support for each other. Thank you. It's time.
So we have 5 minutes maximum for questions. Voice of God here at the back. Hi, ladies. Which we can take a couple from the floor. So if you stay in situ there, Claire, would anyone like to raise a hand and ask a question in here today? No, here we go. Over to Ruth Anna. Yeah, she loves the mic. She's an obstetrician. Here we go.
Claire and I know each other. Do you have, from an academic point of view, because I know you'll probably have done far more reading about this than I have, any particular views on particular kind of models of staff support? Like some units are trying TRIM, some units have got I know the Poppy study, I think, looked at kind of peer support models. Do you know anything about whether there's one thing that's better than another, or are they all kind of much for muchness? Because I think sometimes people fall over themselves trying to get the right model instead of just getting something in there.
Yeah, I think I agree with that. I don't know if there is this. There'd definitely be worse things, a bit like listening services. There's definitely terrible ways to do it, which compound trauma for sure. I haven't done that bit of research, and I think it would make a fascinating question. So I'd love to link with you, and let's do the work. Fundamentally, what staff need to see is that their organisation is doing something, but it comes from them as well. What these retention midwives did, for example, they didn't just decide one day, right, this is what our staff need. They engaged with them. They spoke to them, they did surveys, and managed to get really good uptake on the surveys. They clearly had good weight with those staff. So, and then some things worked better than others, and they took continual feedback. I would say probably the most powerful in terms of traumatic events was external psychotherapy, but having an access to, so outside of the team in that organisation. Whereas Catherine Gutteridge, many of you will know her, previous RCM president, she is a psychotherapist before she was a midwife, and as a consultant midwife, any adverse outcome, she just had this open, it wasn't even open door policy like one-on-one, she would do a structured debrief for anyone who felt affected, even if they weren't in the incident. So this became this really open, supportive debriefing space. So maybe someone was triggered from a previous poor incident, maybe they had their own baggage around it, and this maternal death was just something they just can't move past. So it became this open, really accessible way. But she also had that very particular skill set that obviously not all of us do. She's a psychotherapist. That was on that slide too.
I'm going to do last question just here.
Thank you very much, Claire, for a very supportive lecture to us. As an obstetrician, my name is Sanji. As an obstetrician, I think as healthcare professionals, our focus in terms of training and in terms of maternity services in general is safety, first and foremost. That's what we are always being spoken to about. That's what we are trying to promote in our broken state. But what we are hearing about a lot here today is experience and choice. Has there been any significant research looking at the tension between these two, safety versus choice and experience?
Well, how long have you got? Major study, perhaps not, but certainly in my PhD study, which looked at lots of midwives who support out of guidelines, physiological birth choices, for all the work that's come from that, I've spent years disseminating it. Everyone else must probably sick of it who've heard me speak before. Fundamentally, a lot from that work, and then the work that integrates with that, there is no safety without choice. So there's certainly a big argument that And I think that's what's missing in the organisational, quick tick boxes of what safety means. And even the CQC, which carried out some really extensive PPI work, and they have published it, it's in one of their very long reports. They have strongly recommended that safety definitions of safety it must be beyond the physical. And I certainly argue, and there's other people that argue with me, that emotional safety actually is the crux. Everything else then falls in line. So a woman might make an objectively less safe physical choice. Okay, maybe she's had, I don't know, she's got multiple comorbidities and she wants the home birth. But when you put it in the context of her emotional safety needs, her psychological, her cultural safety, all of those things together, then maybe her choice makes much more sense. And when we can start to value all of those things together, then you've got a properly holistic safety net around. Because when she feels properly supported, or they feel properly supported, they're much more likely to follow your recommendation. Things have changed, right? You're doing so well. This is absolutely amazing, but something's just happened, and I am concerned now. And home birth midwives, independent midwives, will know that they very rarely need to use the voice. This is serious. Unfortunately, in hospital settings, we use that a bit too much. So we become desensitized to what is a genuine safety issue, and to, we're all cracking walnuts with sledgehammers at the moment. So the women who've got so much more information available to them, they just think we're all having them on. So if we want to talk about safety, and safety is everything, we have to talk about it in that holistic way. So there's lots of different strands of work that link into that. And like I say, even CQC now is starting to, and our Beacon project, we look at it from that perspective. The other thing I would say, and I know I need to finish, is in terms of your own practice and taking something forward, is looking at the Safety 2 approach, which really brings in, and it's a bit different to this idea of emotional safety, but the Safety 2, which looks at systems and systems resilience, actually takes a much more holistic approach than this traditional Safety 1, root cause analysis, right, change the guidelines, change policies, right, no one could come onto the birth centre now because they've had a previous PPH. That knee-jerk reactivity. Safety 2 is something that I think is, hopefully maternity will get to grips with a bit more. Thank you. Thank you.
Thank you, Claire. Thank you so much. So important that we consider the lived reality of all our wonderful NHS workers and healthcare professionals. And probably some of you have seen that ABC slide, and really important when we consider our own basic human needs with all of this. So we would like to ask that you stay in your seats, because we are going to be inviting Sakina and the rest of another panel to the stage. So please remain in your seats, and our other workshop delegates will be joining us, and we're going to get going in about 2 minutes.
So, is that, yeah.
So we thought you could see her like half.
You could try it. All right. Yeah. Karaoke. Karaoke style. Yeah, you've got 3 minutes. What I was going to suggest is if I just read you short bios each to introduce you. Oh, hang on, sorry, no, we're waiting for Tina. Is she? So I keep saying Julianne, I was thinking Julianne, no, I was thinking Julianne Boosted. I know. And for some reason I thought she was also doing this and I mixed her up with Cinema. I don't know why. My head is not in normal space. So we're just going to keep it saying it's got Becky. They all look very similar. I just want to make sure that I do it in order. Got Becky, got Camilla, and then we'll have Camilla. Hello. Simon. I think we're ready. Okay, so I think as everyone takes their seats, we're going to make a start shortly. So please make your way in and get seated, and we will start our panel discussion. I'll do that in the intro, yeah. So I hope you've all enjoyed the day so far. We are coming to the space of our panel discussion before we go into our awards and our closing. And as we are marking 10 years of the Birth Trauma Summit, and we've had time to reflect on the work that's been done in the last 10 years, also where we are now, we have an opportunity to think about perhaps what the next 10 years looks like. So we have our panel here, and they're going to be talking to us and sharing their ideas about defining the future of trauma-informed perinatal care for the next decade as we move forwards. So I'm going to introduce them, and to my right, to your left from me, is Julianne Moore, who is a partner at Irwin Mitchell. And Julianne specialises in birth injury claims. So she's had 23 years of experience and a medical background. She champions patient safety and collaboration. So welcome. Thank you for joining us.
Sakina.
And then we have Dr. Becky McGregor, who's an academic GP and an NIHR fellow researching community care after stillbirth. She champions women's health through clinical work, teaching, and national advocacy. Hi. And then we have Camilla Main, who is a consultant midwife, empowering ambulance teams to deliver safe, high-quality emergency maternity care across the UK and internationally. So welcome, Camilla. And Dr. Saima Sharif is a consultant obstetrician and gynecologist specialising in fetal medicine, high-risk obstetrics and women's health innovation with a passion for perinatal mental health. So I'm going to invite you each to share your reflections. We have 3 minutes, so please bear with me if you see my fingers sort of indicate that that's the last sort of 30 seconds. And then we really invite you to ask any questions. We have the Slido. I hope most of you have got the QR code or the link for the Slido. Please do enter any questions that you have for our panel, and we'll have some time after. So Julianne, over to you.
Well, thank you so much. It's been a really interesting day. And when we were asked to take part of this panel, I kind of had a, looking forward about what we would like to see in 10 years' time. And so I kind of took this back and looked at the lens from my field, working as a medical negligence lawyer. I've worked in this field for 23 years, supporting, women and birthing people who suffered from birth trauma. And also, as someone who's birthed myself, I've got colleagues that have suffered birth trauma, family and friends. So looking at those and what's happened in those cases and what kind of there's often similar issues and real key takeaways that I think we can apply and look forward what we'd like to see in the future. And we've discussed a lot of those today. My number one, and I'm very passionate about this, and I spoke about it on a number of occasions, is antenatal education. It's empowering women and birthing people. And this needs to become a standard. It needs to become something that's embedded. And it needs to be very holistic. It needs to be patient-centred. And it's got to be culturally responsive approach. And as someone was mentioning in the last lecture, it's not only prioritising physical safety, but emotional safety, because we see that when I sadly end up with the end results coming across my desk, emotional safety is a real key point. So we really need to embed that, as a standard reflex when we're sort of moving forward in 10 years' time, and I would love to see that. And it's, we've talked about Despina, talked about informed consent. It's so important, making sure that everyone's aware of those options and a roadmap that what may or may or not happen, and that we look at that person as an individual and be respectful of their beliefs. And it needs to start, ideally, before anyone gets pregnant. Can't always happen, but it certainly should be throughout the antenatal period. So when you get to that cold face, and I've worked on a maternity ward myself, you've got minutes. So if someone is aware what may happen, what the choices are, we really need to really embed that. So that's my big key takeaway. Routine mental health screening. We need to assess people in the antenatal period, look at their, assessment of trauma risks, and then obviously build something around them and have that continuity of care so they're not having to repeat the story time and time again. That needs to be embedded. Training, you're all here. That's absolutely fantastic. And we've had, a real shift in the focus of birth trauma, and we need to keep on that. We need to keep banging the drum, and we need to make sure that parades down to everyone that comes across that woman, birthing person and their family's journey. And then we need to, pervade that down into the community as well, that we're training people out in the community, our health visitors, linking up with GPs, linking up with, pelvic physiotherapists. Let's join all the dots. And then we talk a lot as lawyers about guidelines, but, we really do need to have embedded the national guidelines in, about trauma-informed maternity care as standard, ensuring that we're screening, we're detecting, we're treating, birth trauma when it comes as a standard, and we see that all the time. Funding, well, what a great thing, we thought wonderful, wouldn't we? We got all this extra money from the government into maternity, and of course that seems to have bypassed. We do need sufficient funding to allocate resources so we can support women and birthing people with adequate mental health support. So that's a big wish, that people aren't scrabbling around. I hear from clients they're still waiting, weeks, months, etc. for support. I would love to see that. And then having those integrated mental health support. I think we're talking about, was it the maternal mental health hubs? There's not enough of those. Integrating all those resources so, people can access them quickly and other healthcare professionals can tap in to that real knowledge. So those are my key takeaways. And that's what I would love to see in 10 years' time. And hopefully I've not gone over my 3 minutes.
Perfectly to time. Thanks so much, Julianne.
Thank you very much for having me. At the risk of sounding very similar to you, I'm going to give you my thoughts as well. So when I was invited to do this, I went away and spoke to some colleagues and some friends who've recently had babies. And in 10 years' time, I would love to see a healthcare system that allows staff to provide universally equitable, culturally safe, compassionate care that gives women and birthing people the space to talk, be listened to, and have their needs met. Preventing perinatal trauma from happening and remembering that every word counts. Everyone benefits from this kind of care, not just those who are experiencing perinatal trauma. Women and birthing people need to be involved in designing and creating services to ensure that any service created meets their needs, but also that it includes their expert knowledge. We need to recognise that women and partners who've been through birth and been through birthing trauma have knowledge that we can harness and help improve care for other women and partners. We need to empower women from early on in pregnancy and even before pregnancy. We need to equip them with the knowledge they need to be able to make truly informed choices about their care, not just what doctors and other healthcare professionals say is informed choice. And a key part of improving care is increasing awareness of perinatal trauma amongst all community-based staff. I would say that, I'm a GP. And that includes GPs, practice nurses, and healthcare visitors. We know that the symptoms of perinatal trauma may not present until weeks or months after discharge from maternity services, and community-based services may be the first place they go for help. GPs and their colleagues are part of the solution. Staff based in the community, including those who are not maternity specialists, need to be provided with training to be able to recognise perinatal trauma and how to manage this. And even if that isn't that they manage it themselves, that they know how to support that woman and refer them on to someone who can give them the support they need. They need better access to resources, including services they can refer on to, such as perinatal mental health services, with access to specific things to look after women and birthing people experiencing perinatal trauma, as well as considering the introduction of routine screening for all women and birthing people at the 6 to 8 check, which I know is something that Make Birth Better is looking into and hoping to do a pilot in to be able to make sure that's something we can provide in the future. Thank you.
Thank you as well from me for inviting me to this panel. Massive imposter syndrome with these guys. And to speak for 3 minutes on this topic is very difficult. I could probably speak for 3 days on it. I'm going to talk to 3 hats that I wear. So firstly, from the perspective of the ambulance service, women that are at risk of health inequalities and are vulnerable are the most likely ones to call an ambulance during and following pregnancy and birth. And sometimes that's due to the fact that they don't access care because they don't know how to access care. It might be because they're traumatized by care they've received in the past, or it might be an embedded mistrust within their community due to treatment for decades or centuries. Of course, the ambulance service is here for all of us, for society, for people when they're required. And the crews that I work with are passionate and kind and enthusiastic on the whole about what they do. They want to keep the public safe when they're at their very worst, or when we're at our worst. And when it comes to birth, they're not experts, and in general, they find attending maternity cases very challenging and scary, and they'd actually rather attend a cardiac arrest or a big road traffic accident than a birth. So, from a strategic point of view, what do I want from this perspective in the next 10 years? Well, I'd love it that women would know how to access maternity care and the importance of it, and maybe we could start in schools in relation to that. I don't think many of us in the room still use Pythagoras, but lots of us in the room will give birth at some point. So if we think about people in schools and how we could educate from that level around the importance of accessing services and how to do so. I would love to see ambulance services really commit to empowering their staff and giving them confidence to provide maternity care in the pre-hospital setting in the very extreme circumstances that they have to. And I have to say this, but ambulance crews are met with a significant amount of incivility when they arrive in maternity services, A recent survey, 80% of the ones that responded had received incivility on arrival to maternity. And we're all under pressure, and we're all trying to do our best, and they are too. So I really want to see that gone. Actually, not waiting 10 years, but from today. And as a midwife then, just changing to a different hat, I personally, my midwifery soul is never happier than when I'm breathing through a contraction with a woman, holding her and making her feel like a queen as she gives birth. And I would love the UK to look beyond its borders in relation to perinatal trauma and making sure that birth is safe and empowering. So one example of this is something I studied in my master's, which is the Give Birth Without Fear method from Sweden by Susanna Healy. Some of you might have heard of it. And essentially, it's about creating a psychologically safe birth, not for or against pain relief, not for or against intervention, but kind of holding those women through that process. And it gives practical tools that are based on science, and there's a growing evidence base out of Sweden. So we could look beyond our borders for some of the solutions. And as we've heard today, we know that psychologically safe birth, it doesn't just affect them in relation to the birth, but it empowers them into motherhood. And fear that this method is something that is trying to combat doesn't just exist within women, it's actually really rife within healthcare professionals, and we need to address this with urgency. And my final hat that I'm putting on is being an auntie, but also a member of society. So my little niece turned 3 today, and my biggest desire for her and all the girls that skipped off to school this morning is that we won't be sitting here in decades to come having these same conversations, and that Poppy and all her peers will know this as a cultural norm, that women, when they give birth, they're respected, they're listened to, and they're empowered, and that it wouldn't be a conversation because it would just be normal. But I think my last thing that I would say is that it has to be a collective action across the whole multidisciplinary team, primary and secondary care, and including emergency care as well. And I guess the final point is that if one person doesn't sign up to that cultural norm, then it won't work. And I would hazard a guess that actually the people that are not in the room are probably the ones that we need to start with first.
Hi, thank you. It's hard to follow on from that. Thank you so much for inviting me. I'm Saima, consultant obstetrician and gynecologist, and I've been passionate about birth trauma since my own experience after a maternal death when I was a young registrar. So that was my kind of gateway into this area. But today we don't just talk about care, we talk about being fair, safe, and having equitable care. Trauma is shaped by race, it's shaped by class, gender, disability, and I've more and more found out by migration as well. I've worked in London units, it's some of the most cosmopolitan units, maternity units in the world, and I've seen lots of traumatized women that come across to those units. The language barriers and the cultural disconnects can re-traumatize these women. We need to be clear that trauma-informed care must be equity-informed. It's not just what we do, it's how we do it, and for whom. The next decade's goals, language access. We need to use interpreters and translated resources by default, not just by an afterthought. Cultural safety, we need to train our staff, as we're doing here today, in culturally responsive care. Trust building and to recognise historical trauma and institutional racism and mistrust amongst these subgroups. Data equity, we need to collect and use race, language data and identify gaps so we can work towards getting them dealt with. The other thing I'd like to focus on, because I know I don't have much time, is health tech. Everyone knows AI, digital transformation is happening in the NHS trusts. We need to be there at the beginning. Our voices need to be heard. We need to be represented in the data sets that are being fed in to the AI, health tech, algorithms that are being created that will be in use in our hospitals soon. Digital translation tools, hopefully for real-time respectful communication, will come from these. We may have AI screening tools for trauma and mental health, and in many languages. We need to create apps, portals tailored for different cultural contexts, and remote support. So virtual doulas, therapy, peer networks to reach the underserved areas that we're not reaching ourselves. Final message, so future of trauma-informed care must centre around inclusion. Tech is not the full solution, but it's a powerful tool that we need to be thinking about and need to be integrating our learnings into, so the underserved and the women who most need it will be, reached to. So we need to build a system where every person in every language feels heard, safe, and respected. Thank you.
Thank you very much all. Such, I think, insights and some real hope for what's still to come and some direction forward. And I think there's some real themes that came through there. One of listening and inclusion, and really considering who are not in our spaces, either in our sort of the minds of our systems, but also in our training spaces, our awareness spaces, but also how do we start to really link up the work that we're doing. So we're not just thinking about continuity for those we care for, but we're thinking about continuity and a kind of holding within our systems. So thank you. We've had some questions, and there are some questions for sort of individuals, and if we have time, there are a few that I think we can answer as a panel. So I'll start with you, Julianne, if that's okay. We have a legal question. Is it possible to take legal action which focuses on enforcing change as opposed to seeking financial compensation?
It's quite an interesting question. So most people think that people that have suffered birth trauma come to us as solicitors for the primary aim of getting compensation. That is, if there is a successful point, the end point. But most people come to us because they want answers. Usually something's happened, there's a close down, there's no duty of candour, and to help with them understanding what's happened and why, they come, to solicitors to look for answers, but they also want to affect change. So often, certainly at Irwin Mitchell, we come and do lots of things like this as well. We go to individual health trusts, etc., and do lots of training and education. So most people generally come to us initially because they want answers, and they also want to stop it happening to someone else again, and affect change. And legal cases do that. It's sad because it's reactive. We want to be proactive. So, that's a lot of people do come to us for that reason as well.
Thank you. And I think that's very true, isn't it? When we hear people sharing their experiences, it's the change that they're also really, really seeking. Thank you. Becky, I wonder if you would consider answering this one, which is, what impact would continuity of carer have for all in reducing birth trauma rates?
Wow, that's a very big question.
Just a small one.
So, along with being a GP, I'm doing a PhD looking at how we care for women and partners who've had stillbirths and second trimester miscarriages. And the stories of the individuals who are helping me do that and helping me co-produce my PhD tell me again and again about the re-traumatization of having to tell your story again and again, and that every time somebody asks what happened, or even worse, asks where the baby is, all of that comes back and it's made 100 times worse. And so actually we need to start talking to each other across professions. We need to communicate between the hospital and the community, and we need to have people who are trusted, that women feel that, and birthing partners and birthing people feel that they're able to actually feel safe enough with, to be able to say, this is what I need, without us re-traumatizing them. So I think that's a very short answer to what you could have an entire week's conference on.
Yeah, I think we could do a whole panel potentially just on that. Simon, I wonder if you'd be willing to perhaps add some thoughts on that too.
I think continuity of care is really important. I'm a big fan of doulas. Probably people think key obstetricians aren't, but I'm a big fan of doulas. I think they provide that breathing space for the couple or the patient to make decisions. Continuity of care in our guidelines has been proven, as they state in guidelines, to a successful delivery, whether it's C-section or, vaginal delivery. But the system, the way it is, I'm sure my midwife colleagues and obstetrician colleagues here know, we're strained. The feedback that I see from patients, majority of time is, I said this before, I explained it to the midwife before, I explained it to the previous doctor. I was told I can have a C-section, for example, why can't I have it? And it's the system we're working in at the moment, okay? One of the previous speakers talked about, having sessions one-to-one, explaining, the eventualities of a C-section. We need solutions. And I'm going to mention the health tech AI solutions here, because I do think things like AI scribes, I know it's not a health tech solution, but I do think that will help alleviate the burdens of the NHS admin in the next 5 to 10 years. So I'm really hoping those things, but we need to be involved in driving the data into those systems, so then those women are benefiting. And hopefully then there are more staff available to be the continued support midwife of the doctor. So I think it's quite an interesting space at the moment. Hopefully these things may happen.
Thank you. And I was also thinking about Claire's talk earlier, where she's very much talking about the systems and how good tech can really free up time, but also help staff feel cared for and therefore be able to pass that care on, as well as the practicalities of actually having the time and potentially resources for continuity. Yeah. Thank you. So Camilla, I have a couple of questions here for you that I think are similar. So I'm going to ask you one of them because I haven't quite figured out how to amalgamate them really well. So I think they speak to something quite similar, but the question for you was, how specifically can ambulance services empower staff regarding maternity care and perinatal trauma? And could you provide specific examples? Very specifically, sorry.
Yeah, no, that's fine. Well, we are trying to deliver a lot of training in relation to emergency attendance during pregnancy or birth, and empower the ambulance clinicians with the right algorithms that are not hospital-based algorithms that have been put into the pre-hospital setting, but they've actually been created for the pre-hospital setting, where you don't have a big red button on the wall and you might never have delivered a baby before. So those kind of things are in progress, and we basically have a national network, the National Pre-Hospital Maternity and Newborn Care Group, which I co-chair with a consultant paramedic from the Welsh Ambulance Service. And so we, across the 4 nations, are kind of triangulating what we know about the women that are calling us and what they need from us, and talking to the women and understanding from the communities after the event to see what we can do to improve their experience and outcomes in these situations, because they are at risk of higher risk of having morbidity and mortality just by the fact that they are having an emergency situation during or following pregnancy. It's specifically related to perinatal trauma. It's difficult because these are people that are as scared as the woman that is delivering, in an unplanned way. I'm not talking about home births here. Actually, the home births where the ambulance service get called, they're not the ones that we worry about, to be honest. That's the maternity services often focus on those ones. These are women that have called us, they haven't had any care in their pregnancy. Maybe they've recently arrived to the country, and then we arrive to somebody that's supposedly a 50-year-old man who's called us with rectal bleeding. But when we walk in, there's a woman and she's just given birth to a 3.5 kilo baby down the toilet. So these are the situations where we need to be wrapping that woman into our arms as a system, as a collective, together, collaboratively, because that's a very traumatic event for her and for the staff involved. But it's work in progress, and the first step is for the ambulance service to be seen as a system partner in relation to maternity care, and that's not currently the case at most levels strategically in the UK, but we're working on it.
Thank you. Yes, definitely more in terms of inclusion and collaboration. We are at time for our panel. I know it goes so quickly, and I think we could carry on discussing this topic and in so much more depth. But as we close and we think about takeaways and moving into the sort of next decade, we had a question earlier that perhaps we could try and answer with one word or one sort of phrase as a takeaway from each of you. If you could change one policy or protocol in our maternity system, what would it be? And perhaps, Julianne, I could start with you and we can work across.
Knowledge.
Safety in all its forms.
Collaboration.
Funding and training.
Thank you. Thank you. I think they're amazing words for us to take away and think about, and it's been a real pleasure having your insights. So thank you, each of you, very much. So thank you to our panel. We now have Rebecca coming back as we're moving into our closing. And we have some awards to give out.
So I know, can you hear me okay? Yes. So I know a lot of you have been filling out your evaluation forms. Thank you so much for that, because it really helps us to listen to feedback and make next year's event even better, hopefully. So this year, for the first time, we have some awards. And the first award is for Birth Trauma Changemaker. And we're delighted to announce that we have chosen Leah Lewin. Leah is not here today. She is in Jamaica, but I know that she is watching online. So many congratulations to Leah. So to Leah in particular, we wanted to recognise her amazing commitment to advocating for systemic change. Particularly through her training around obstetric violence and with the White Ribbon Alliance, and her deep commitment to addressing the intersections of race, trauma and perinatal health. She is a forceful and amazing change agent, and we're really proud to honour her vital contributions to the field. You're going to do the next one? We've done Susan already. Oh, yeah, okay.
So our next award we'd like to give out is for Birth Trauma Project, and we'd like to award this to the Calm Connections Clinic. And so we're really delighted to give this to Calm Connections Clinic, who are part of the Walsall Healthcare NHS Trust. And this is really in recognition of their pioneering support for parents who are navigating baby loss, birth trauma, and mental health challenges. So the clinic is run by dedicated midwives. So we have Tracy Denmaid, Laura Atkinson, and Hari Nijar. And this is a one-of-a-kind clinic that provides safe, compassionate space for families to heal. So we're really proud to celebrate their work, commitment, and just to express that that they say no parent faces their journey alone. So congratulations. Okay. If you are here, please do come up, because we have an award to give you. Now, As you receive your award, please do give them a massive round of applause. Unfortunately, we don't have time for everybody to give an acceptance speech, but please do look up at their work. Oh, that's so... It's a really emotional moment there. So our next award goes to Birth Trauma Project, and this is for the Kent Health Visiting Service. And we're absolutely delighted to give this award. And this is really in recognition of their UK leading approach in improving assessment support for birth trauma. And they are helping countless families access the support they need, validating their experiences, ensuring better outcomes for parents and babies alike. So we're really proud to celebrate their commitment to transforming care pathways and making a lasting impact on the lives of families that they support. So please give them a massive round of applause and do come up.
Okay, and our last two awards are for impactful organisations. So firstly, we're delighted to present this award to Fatherhood Solutions, led by Scott Mayer, in recognition of their groundbreaking work supporting fathers during the perinatal period. They have a deep commitment to mental health, family well-being within the perinatal period, and challenging outdated gender norms. Fatherhood Solutions has transformed the way services engage with dads, and their mission to empower fathers as equal caregivers is making a lasting impact in the lives of countless families, and we're really proud to celebrate their vital work. And I know Scott's here. Okay, and last but not least, we'd like to give the last award to AIMS UK. AIMS were actually at the very first workshop that Emma and I ever ran when we were developing Make Birth Better. And this is in recognition of decades-long commitment to transforming maternity services, and one of the original advocates for change. They've been a powerful voice for birthing people and their families, and tirelessly campaigning for change in maternity services. So please come up. AIMS.
Thank you so much for all of the nominations. We had so many exceptional nominations, and it really was a difficult choice, but we're so proud to honour the awards that we've given and also recognise the work of so many individuals and organisations who are campaigning and supporting change. So as we start to move through and reflect on our day together and come to a close, we have our poet in residence, Vika Vink, who's been here all day. Vika is also a champion, and she is a London-based spoken word poet who writes both in English and Dutch, with powerful themes including culture, climate, and human rights. So alongside her poetry, she works in the UK refugee sector and is involved in a range of grassroots community organisations. So as I mentioned, Vika is also a proud and loud, thankfully, MBB champion, and she's using her voice to raise awareness through creative expression. So we're absolutely delighted that she's going to share a poem she's crafted throughout today to mark our 10th annual Birth Trauma Summit. So, Vika.
Thank you so much for having me. Can I use that mic? That will be... Can you hear me like this? Amazing. That will be helpful because I haven't had time to write this out loud in the old-fashioned, write this up in my notebook in the old-fashioned way. But I've been making notes all through today. I've also been speaking with Becca. This poem reflects lots of the conversations we've had today. It's also informed by developments in national and international law. But I'm also a parent, and so it's also informed by developments in Peppa Pig. This poem is a bit long. Don't worry, I'll send the text over as well, but it's intended to be a sort of journey through the day today. So feel free to sit back and listen. It's called We Carry Our Babies. As fever blisters on my lips and heartbreak blisters on my phone, we come here today to organize around hope, making our ways in the May morning from the Windrush, Lioness, and Mildmay lines as we mark a decade of pioneering in perinatal care in this Conway Hall on Red Lion Square. Today, on the anniversary of the birth trauma inquiry, which was historical yet limited, we were bound to get expansive, when we mix our personal and our legal views, where every voice matters as a little baby stretches their vocal cords, and we commemorate, great timing, and we commemorate a decade of birth trauma support. Well, we are not looking for a quick fix. It's not about good babies. It's not about feeding or napping. It's about holding whole family units. As bit by city bits, we get a clearer picture of treatment, support, and remedy, informed by the Oxford English Dictionary and common sense in our demands for equity. After years of pandemic, today we have come full circle. We are back in person with people in the room and participants online who slide into our DMs and Slido, and staff of Make Birth Better ready to make new transitions of refreshed leadership. In this place where the first conversations about Make Birth Better were started, where the organization started gestating, in this Conway Hall whose leaders spoke in town halls of the questions shaping the directions of the centuries that have gone before us, as we now play our part in shaping the stories of our time and the ways in which we carry our babies. To thyself be true, speaks the stage, in this venue where people have always been rebelling, been reforming, been thinking, as Conway Hall society is explicitly outspoken about hoping to help people live free lives. And we talk about women, we talk about parents, we talk about birthing people. We let people choose for themselves, for there's no such thing as reproductive justice when it's placed upon binary opposites. Instead, we learn to widen our language. We learn to say, I'm really sorry. I'm here to listen, and I might get it wrong, but I'm here to help you. What do I need to know? We talk about allied professional skills of understanding and saving the details for those who can hold them. When I spoke to Becca, she mentioned that the summit is a bit like a wedding. As a poet, I pondered the metaphor, and it is true, humans gather when things are hard and difficult too. And these times are hard, there is so much hurt, and this indeed is a space to hug, to listen, to celebrate those who have worked so hard, shower them with an award, show our appreciation. And to meet colleagues who you have worked with on a project years ago, say a quick hello, learn new life updates, hear about exciting new services elsewhere, as you are both working the sum of your parts with your skills and heart in different parts of the UK. And we know we have in this nation some world-leading services, strong peer support and debrief tools, yet also an NHS so severely under pressure that people are told to trust themselves as they can't trust healthcare access. When people are birthing in systems with systemic discrimination, with disproportionate outcomes for marginalized populations, and partners, parents, birthing partners sidelined in conversations, systems stretching out in legal constellations. So I wonder, In Holborn, are we born whole? In a London filled with red buses and traditions of resistance, can we be expensive and understand what ethics is asking us now, as we are back to basics? We only have to hold our phones to know some basics of our current times. Lives should not be bombed, should not be deported, should not be processed elsewhere. We honor life where we find it. As birth workers, we know this. And so we hold the line, as I know so many of you do in your day-to-day, for no child should struggle to survive, for these are all our babies. And we know this because all of us collectively have seen so many lives wished for, so many lives longed for, hoping for breath after breath. And caregiving is not in grand gestures, it's in noticing, in repetition, in insistence. So let me speak and say, birth work is political, birth work is magical, and all we have to do is bring the essence of birth work in every space we go, every step of the way, 10 years on from that first summit in Bow. Be through to thine summit, from our foundation of lived experience, learning, and community. As our panelists say, there's no need to be popular as long as we are purposeful, and you are not alone. You might be in any given meeting, but look around you today. Here are your colleagues, your cohort, your team, with millions of years of experience in one person and in the audience, so that in 10 years from now, we talk differently about babies, about resources, about fertility, as we find community in podcasts, halls like these, and honest stories on Women's Hour, translate trauma skills in 21 languages, and create spaces that are tenderly caregiving. We know we can ask everyone in the room how they're doing. We can bring new people in, and none of this will make the sound of revolution. They will make the sound, the clamor of keyboards and human connections and ultrasounds. But together, these actions can make destruction falter and sprout more reverence for life, so children can see adults acting responsibly, so that they can live lives that are joyful and healthy and free, so their thoughts can wander off to think about the new sibling of Peppa Pig on telly. Whilst we adults keep speaking up for health and safety for all, for a world in which no one has to feel small. For being in Conway Hall today, we know that big structures can be thought through, altered. We know we can change the fault lines amongst which we organize. We can protect everyone's right to life and fair access to safety and healthcare for all. We can center the voices that matter, for these are our babies. These are all our babies, and we carry our babies in our minds, even when they are not yet, or no longer in our bodies, even when they are not in our worlds, because these are all our babies, and this is all our world. Thank you. Thank you.
Okay, can you hear me okay? We'd just like to finish by thanking everyone who's been involved in making this event such a great day. So to all our delegates and speakers, to our partners, in particular Owen Mitchell and Lee Day, to all the exhibitors and the people who have contributed to the goodie bags, to Conway Hall for hosting us, and for all of those who contributed research and creative work. Particularly to our Make Birth Better champions who are always on hand to help, to support, who give so freely and passionately of all their time and expertise, and to our small but mighty Make Birth Better team. And we're going to close, hopefully, I think we're going to have the slide with our word cloud that we have captured, that I know you've been contributing today. So yeah, this is just lovely to see, and lovely to see that joy and healing are right there in the middle. So thank you so much to everybody who's come today. It really means so much for you all to be here, and we will see you next year. Thank you.